All right, good afternoon, everyone, and thank you so much for joining us today for the third event in our ongoing series of COVID-19 vaccine town halls presented by the Globe and Mail and the Royal Society of Canada. I'm Kelly Grant, a national health reporter here at the Globe and Mail, and I'm pleased to be your MC and moderator for today's event. The Globe and Mail and the Royal Society have been collaborating for a number of months now on the Zero Canada project. It's an initiative that seeks to direct us all towards the first day that Canada can report zero new COVID-19 cases, which is a day I'm sure we are all very much looking forward to. Our hope is that this series of town halls will provide a public good in presenting the information Canadians need in the fight against COVID-19 from leading experts across the country. So before we get started and I introduce our expert speakers, I just do have a few housekeeping items that I would like to attend to. So the first is, if you are experiencing any technical difficulties, please do let us know via the Ask box on your screen. Our producers are working hard in the background to try to make sure everything goes great on the tech front, but we all live in a Zoom world now, and you never know what you might expect. So do please ask if you run into any of those issues. As well, I know that ahead of time, many of you submitted some questions, and we will have about 15 minutes at the end of the event to deal with audience questions. If any of you would like to add questions during the course of the panel, you can go ahead and do that in the Ask box as well. Everyone who registered for the webcast will receive a link to the recorded version, so you can watch the event again afterwards as a recording if you'd like. The link will also include some information and a link to the past town halls that we have hosted on these subjects in January and February. Got some links, I think, up here on the screen that can point you to a couple of other places that you can get information, including from the people who are helping to put on today's event. And so speaking of that, I would like to thank everyone who's been involved in putting on the event today. And the organizers include the Social Sciences and Humanities Research Council, the Natural Sciences and Engineering Research Council, and the Canadian Institutes of Health Research. Finally, if you'd like to follow along on social media during today's event, please follow at the Academies, that's the live tweet, as well as to stay up to date on news and events from the Royal Society of Canada. You can also follow at the Globe Events on Twitter, and that'll take you to some more information about the events that we hold. All right, so without any further ado, I would like to introduce our esteemed panelists. We're really lucky to have this group with us here today. And I'm going to begin by introducing Dr. Charu Kausic. She's the scientific director of the CIHR Institute of Infection and Immunity and a professor in the Department of Medicine at McMaster University. In her role at CIHR, Dr. Kausic is responsible for making decisions for strategic investments in the areas of infection and immunity, and she represents the organization as well as the Government of Canada at various national and international forums related to infectious diseases. So welcome, Dr. Kausic. Next, I'd like to introduce Dr. Krajden. He's the medical director of the Public Health Laboratory at British Columbia's Centre for Disease Control, as well as a professor in the Department of Pathology and Laboratory Medicine at the University of British Columbia. He's also involved in the BC Hepatitis Testers cohort and is the medical head of hepatitis efforts at the BCCDC. In addition, he serves as an adjunct scientist with Canadian Blood Services and is a member of their Scientific and Research Advisory Committee. So welcome, Dr. Krajden. I'd also like to welcome Professor Bartha, Knoppers, who holds the Canada Research Chair in Law and Medicine and is the director of the Centre of Genomics and Policy in the Faculty of Medicine at McGill University. Since 2005, she's led the policy committee of the Canadian Stem Cell Network, and she currently serves on Canada's Vaccine Task Force and works with the COVID Cloud on DNA Stack. So welcome, Professor Knoppers. And last, but certainly not least, please join me in welcoming Dr. Lisa Richardson. She's a strategic advisor for Indigenous health with the Faculty of Medicine at the University of Toronto. Dr. Richardson is a mixed blood Anishinaabe physician and a clinician educator. She practices general internal medicine at the University Health Network, and she's a researcher at the Wilson Center. She's a scholarly focus on integrating Indigenous and critical perspectives from the social sciences into medical education. Welcome, Dr. Richardson. All right, thanks again to all of you for being here. I figured the best thing for us to do would be to start at a high level. So I wanted to come to Dr. Kausic and ask first, simply, what are variants of concern?
Thanks, Kelly. That's a question that gets asked a lot. So Let me start a little bit from the basics of what viruses do and why should variants of concern be of particular concern to us. So viruses need a host to be able to live and replicate. So when they come inside, their genetic material, which in the case of SARS-CoV-2 is an RNA, which is kind of like an Instagram where it's there and then it's gone. While the proteins are being made. When that happens, the replication of the virus involves copying that RNA to make more copies of itself. In doing that, viruses, not just SARS-CoV-2, but most viruses make mistakes as they make those copies. In particular, RNA viruses are particularly prone to those mistakes. So we call those mutations, substitutions. There's different kinds of mutations that happen. When SARS-CoV-2, we've known this for now 15 months, that when SARS-CoV-2 replicates, it makes mistakes. And those mistakes, which are called mutations, when they happen, they're generally not of concern because most of them happen in areas where it doesn't really affect how the virus behaves. When there are a significant number of mutations, that's more than the usual number, which is 1 or 2 mutations, every 20-25 days when the virus replicates, then it's something to notice. And in particular for viruses of concern or variants of concern, there's a large number of mutations that have accumulated in these variants. And many of them are in areas of the virus that make proteins that are used for entering the host cells. So I'm sure everybody's heard of spike protein a lot. So in particular, when these mutations happen in the spike protein, it changes the way the virus behaves biologically in terms of entering the cells, entering the host, how much it transmits, how severe is the disease. That's where we start worrying about the virus, and that's where we flag it as variants of concern. So that's the term you're probably hearing a lot. The other terms that are used is variants under investigation, where we don't yet know how important it is to follow the virus or the variant. And then there are variants of high consequence when it's clearly known that the variant has significant effect on the disease severity and death and outcomes of the disease.
So most of our viewers have probably heard the most about 3 variants of concern, one that was originally found in the UK, one in South Africa, and one in Brazil. I wonder, can you take us through each of those 3 variants and tell us a little bit about them, and then maybe talk about how vaccines respond to each of them?
Yeah, so I'll try to be brief because obviously there's a lot that has happened, since December. So in the middle of December, the reports started coming in. I think it was 18th of December that I was called to the first meeting to discuss this variant of concern that was happening in UK, which UK had reported to WHO. This variant, which is now known as B117, we're trying to avoid labeling countries with specific kind of variants because it's just the first place that they were reported. So B117 is now known to be highly prevalent or present in more than 90 countries. It has about 23 to 25, substitutions, deletions, and mutations. And what it means is that over the next 2 months since December, it's become clear that means that it has about 50% more transmission. And just in the last 3 weeks, it's becoming clear that it may also be associated with more severe disease. So about 30% to 50% higher severity and maybe even death rates, although that's still being looked at. It also is harder to detect because of the changes, some deletions that have happened in it. Finally, it is also being shown to circulating very quickly in many, many countries. So very high transmission rates. It's here in Canada. We just heard this morning a meeting where in Ontario, about 80% of the cases being reported now are of this B117 variant. The South African variant, which shouldn't be calling it South African variant, it's actually the technical name is B1351. So the variant which was first observed in South Africa is a little bit different. It also has a large number of mutations, about 21 mutations. And it is now circulating in about more than 50 countries around the world. The main thing to note about this is this particular virus, and all three viruses that, the next one I'm going to talk about as well, they have changes in the area where they bind to the receptor. So that spike protein changes, which changes the way they transmit. They can be higher transmission. The 351 is of most concern because among all the different variants of concern, that one looks like it may be the most capable of bypassing the immune responses. And then finally, the P1 variant, which was first reported from Japan, but actually originated in Brazil, which is, we just call it P1. That has many features that are in common with the 117 and 351. Unfortunately, the thing to note about that variant is that it's causing a third wave of infections in Brazil, in Manaus area, where it is most heavily, found. And what that means is that people who were previously infected are now getting reinfected by that, meaning that the previous immune response was not good enough to protect against this variant. One thing that I'll add is that among these variants of concern and others that we are closely looking at, there's some from New York, California, and other ones, there seems to be a significant part of the virus that's in the spike protein. So there's two variations, the 501 amino acid, which is a part of a protein, and the 484 part of the amino acid, which is particularly concerning because many variants have this in common, and they have some features in common, as in they're able to bind better, and some of them have this property of being able to bypass immune system. The good news is, in response to your last question, none of them seem to be able to completely bypass the response from vaccines. And that means all vaccines, whether it's Pfizer, whether it's AstraZeneca or Moderna, all vaccines seem to work very well. There's some decrease in the efficacy or how much the virus can be neutralized, but it really doesn't affect the level of protection yet.
Okay, thank you very much. That's a lot to cover, so I appreciate you sort of wrapping it all in for us. You mentioned in there about Ontario now estimating new, sort of the percentage of new cases that are variants is in the range of 80%. Dr. Krajden, if I could maybe go to you next. You run the lab there in BC. So how is Canada surveying and looking for and testing for these variants?
Thank you, Kelly. Well, when you go for a diagnostic test, that's typically done by a technology called polymerase chain reaction. And that essentially takes the nucleic acid in the sample and it amplifies it approximately 1 million-fold or more. And then you can diagnose the infection on the basis of specific binding to certain probes. When you're trying to quickly try and diagnose whether you have a potential variant, there's a screening process where instead of targeting the virus itself, you're specifically targeting the variant. And the ones that people most commonly target are this 501 or this 484, as Charu mentioned. That just tells you that you have a probable variant. And in order to determine if you actually have a variant, what is necessary is an approach called whole genome sequencing, where you actually do genomics and you sequence the entire virus, which is about 30,000 base pairs or letters. And essentially, you're able to very finely discriminate any mutation or variation that occurs in that genome. And that's typically done when you're trying to determine if a long-term care facility has been infected with a certain strain or within a hospital, or if you're trying to study whether or not kids gave it to their parents or parents gave it to their children. So you can actually do a fingerprint of the virus and compare it. You can also do it to test in travelers to see whether or not traveler has a variant that originated from one of the countries that was discussed. And one of the approaches is to do random or unbiased sequencing, where you're just sampling the general population of anyone who's positive to try and determine whether or not the person has a variant. And I think one of the things that I'd like to convey is that pandemic responses are really very interdisciplinary. There's the political component, there's the scientific component, there's the public health component, there's laboratorians like myself, there's clinicians, modelers, and immunologists like Charu. And I think the challenge for us is we're in a five-way race. At the center are people who are tired of lockdowns, tired of curfews, some of whom can protect themselves, versus others who are vulnerable, or they have to work, or they live in a congregate setting, or they may live in a household with no running water. As Charu highlighted, the virus basically does like Darwin says, survival of the fittest. It's trying to replicate. And what we're seeing is we're scrutinizing this virus with tools that didn't exist 10 years ago. Over 1 million of these viruses have been sequenced. And even in the UK, in order to show that it was more infectious or potentially more severe disease and potentially less responsive to vaccines, you needed to correlate not only that sequence, but also the epidemiology. And as you know, we have these great vaccines, and AstraZeneca, for example, is in the news. It continues to be in the news, but all of these vaccines dramatically reduce your risk of dying or developing severe disease. And that has to be the most important piece. Also, as Canadians, we all recognize that we have limited vaccines. We have a slow deployment of vaccines, and this has led to a lot of controversy, delaying of the second dose. And essentially, we know from the UK, we know from British Columbia and Quebec that even after the first dose, you dramatically reduce deaths, severe disease in long-term care and healthcare workers. The immunologists hate this because they're looking for perfection. But think about it this way, perfection for a few is not as good for many. And that's one of the reasons delaying the second dose has some value. And then I think the biggest challenge for us as a society is when we just protect ourselves, it's being short-sighted. We are in a global village. We can't be in a Canadian bubble only. And much of the world won't be vaccinated for the coming years. And that gives an opportunity to even more potent variants to emerge. And those are some of the challenges we face as a society.
So I suspect we're going to get lots of questions from the audience at the end about both AstraZeneca and Canada's decision to delay the second dose. So I'm looking forward to talking about those a bit more. But in the meantime, could you just tell us, Dr. Krajden, do we know yet how prevalent the variants are in Canada? What's our surveillance telling us?
Well, if you check on the Ontario website, they had about 54% of their variants are derived from the UK. In Alberta, it's about 30%. In BC, it's around 20%. And the levels of the variants in relation to South Africa or from Brazil are lower. But they're in our country, they're being transmitted in our country, and time will tell whether they continue to transmit. And part of that depends on the health measures that people adhere to. And some of them are more transmissible. So the health measures that worked for the original strains don't work as well unless you really pay attention to them.
I want to turn to Dr. Richardson now and talk to you a bit about the inequities that the pandemic has revealed in our country over the last year. And I wonder if you could speak a bit about how the variants play into that story.
Thanks, Kelly. This is definitely a zooming out kind of question. So we've been talking about everything at the molecular level. I think it's very clear that COVID has exposed major inequities. And I'm just going to run through some of the data that we have. So I work in the GTA, and we have robust data here, but much of it is replicated by what we're seeing from the recent StatsCan report that was released. So what we know, for example, in Toronto is that 77% of people who get COVID identify as racialized, whereas the census data from 2016 shows us that racialized people in Toronto only make up 52% of the population. We know that from data on reserve, the rate of COVID for First Nations people living on reserve is currently 74% of what it is of those, higher than it is for those living off reserve. We know that for people living in low-income neighborhoods, from the Ontario Science Stable data, the likelihood of mortality of a 50-year-old living in one of our lowest postal code areas is the same as the mortality of an 80-year-old living in a high-income postal code area. We know that people experiencing homelessness are much more likely to be hospitalized and to die. We know from the initial terrible outbreaks and spread of this virus in long-term care facilities that those people in congregate settings were at high risk. That applies to those in the carceral system, meaning in jails and other congregate living settings. And we look at the effects of healthcare workers and essential workers. The bulk of those people who were infected in long-term care as the healthcare workers are racialized women who are in contract role positions without paid sick leave. So how does that vary? How does the variant make this worse? This is all data, by the way, from much of it is up to December 31st. So we add in now variants that have increased transmissibility, so they spread more readily, and increased virulence, meaning increased disease severity. And there's a range of studies around that. This means that addressing those social determinants of health that are what have led to the existing inequities in the first place are more important than ever. Because if you are living in a tight environment with a dwelling where you have families of different ages across multiple generations of families in a tighter home, if you are living in a crowded circumstance, if you do not have access to clean water, food security, etc., these variants are even more likely to widen the inequities that we're currently seeing. I will say, though, that even as I said before we even had these variants take hold, the inequities are massive. I haven't seen, I think, enough of a response to address them. We're rushing to vaccine, but there's been a lot of resistance around understanding why certain groups may be prioritized. And it's really important to recognize that they're being prioritized based on our data. So I think, the variants, I am concerned about them further widening these existing inequities.
Yeah, would you mind if I just followed up and asked you, Dr. Richardson, what do you think are the biggest things the government needs to do to address some of those underlying inequities?
When we look at, for example, the data around racialized people, it's really important to understand this is not a biological issue. This is an issue of what we call structural racism. This is about having to be an essential worker without paid sick leave, or without food security, or living without a secure place to live. So we need to address those upstream factors that are increasing the likelihood of disease, of transmission of an infection. Similarly, we need to address those chronic illnesses that also put one at risk of having more severe infection. So again, although I'm an internist, so I'm on the front lines treating people in hospital who are acutely unwell with COVID, because of my work in equity, I have to actually step back and say, what are we doing upstream to think about those social determinants? I
think that's really, really important stuff. I'd like to turn, though, now to Dr. Knoppers in a bit towards the future here. And that is another topic that we've been hearing lots about is the idea of immunity certificates. So Israel, for example, where they're quite far down the road of vaccinating their population, they're giving out these green passes that allow people to do things like go to concerts and all the things that lots of us are dreaming about in our day-to-day lives. So I wonder, could you tell us a bit about whether you think these kinds of certificates are a good idea and how you think the emergence of variants might affect our discussion around this? Because, if it turns out that some of the vaccines don't respond as well to some of the variants, what good is an immunity certificate?
Thank you, Kelly. I think, first of all, we'll have to distinguish these green passes from immunity certificates, sometimes also erroneously called immunity passports. I think we're going to see very different, just taking Canada, very different responses across the country to green passes, because it's very much a social, cultural peace of mind and an expression of the values of a particular community that you find in the tolerance or non-tolerance, acceptability or non-acceptability of green passes. So we will see a variety of responses across Canada, due probably to the same reasons: lockdown fatigue, effect on social and family ties, psychological isolation, and so on. How communities respond in provinces in particular, I think we're going to see different degrees of social cohesion to the acceptance of green passes as a way to open up or begin to feel at ease with living together as a community again within Canada. Now, that's quite distinct from the immunity certificate / passport, which is being discussed at the international level, as you know, quite a bit. I still have my smallpox scars as an immigrant. I remember going to South America and other countries and getting yellow fever, and then the little booklets you have to carry around. So it's not a new idea of preparing or vaccinating yourself against risks of COVID-19 in this case. But I think there's four main issues that make this an international subject. The first one that always comes up is our economies need it. This means economy writ large. Economy also meaning the health of individuals within an economy, because their health is affected by the downturns and ups and outs of the presence or not of vaccines within different countries. The second concern that people raise, so that's a plus. They say if we have these certificates, we'll have more travel, we'll have more business, we'll get back to normal. And so that's economy / health. The second main point of discussion then becomes a security privacy one. And that surprised me that this came up so much. How secure are they? How many fake ones are we going to see? Will there be a black market for this? And what will this do to our privacy? Well, once we're in the system, sort of like biometrics, the government will follow it, and we'll lose our autonomy. We gain our autonomy in travel, we lose it in surveillance and so on. So that's the second, the tracking, tracing phenomenon. The third, which was just raised by Lisa, is that of equity. And what really surprises me in a global pandemic is how, and this was mentioned by Mel, how non-globally people think. They don't realize we're not going to get out of this unless we have global solutions and work together as a global community. And here is where it's not just a matter of COVAX and sending vaccines to those countries so they can start their programs and catch up and we can all get through this together. It's also, why aren't we doing more at the World Trade Organization, for instance, to have different patent exemptions in place for these vaccines so that countries can afford them, and that'll be more equitable distribution. And the final point, I think, is we don't know about these variants and the vaccines that have these new RNA vaccines, a first in world history, by the way, RNA vaccines. We don't know how long the immunity will last, how good it'll be, when will transmission risks reemerge. Worst of all, we don't know how long they last. The clinical trials are only a very short period of time. Maybe all our vaccination efforts will have to be redone again. And then with the new variants, maybe we'll need new vaccines again. Hence the importance of looking at a more equitable approach to intellectual property and distribution of vaccines as we move forward in time with new variants and new global needs, I think, in response, in terms of vaccines, in response to these variants.
Yeah, I like the point you made there about we just don't know a lot about what's going to be ahead for variants in the vaccines. But Dr. Kausic, if I could turn to you, one of the things we do know is that in the countries that saw the variants, particularly the B117 variant, really emerge and sort of take over cases and drive very high spikes in December and January. I'm thinking of places like the UK, like Ireland, like Portugal. All of these countries did manage to bring their case spikes down dramatically. And for the most part, that happened really before their vaccine rollouts really got, up to sort of like a critical mass. So could you talk a little bit about what we can learn from those countries that have already been through this sort of first big spike caused particularly by the B117 variant?
Yeah, thanks, Kelly. So it's it's a really good discussion, on how to deal with variants. The bottom line, I'll start with the bottom line. Health measures are the same. We're in a much better place than we were, say, last March and April, where we were so worried about, we didn't know how transmission was going to happen. I remember lots of discussion about fomite transmission. That means, can you get it from touching things? I remember ordering groceries for 3 months, not wanting to go into supermarkets. So we are in definitely a much different place. We know exactly since last 12 months that the transmission primarily happens through person-to-person, close contact, closed spaces, confined locations. The 3 C's are still the same, whether it's a variant or it's the older strain. The interesting part that comes out from looking at the way the B117 was controlled, particularly in UK, because they did a very good analysis of what it was going to take and how they brought it under control. They saw that in different parts of UK, where in one part or in the southeast part where the 117, took off first, compared to other places in the country where the older strains were still prevalent. The measures that they were taking to close down and control the public health measures were working much better in the places where the old strain was. That degree of shutdown was not working for 117. So when they looked and compared in the same place, same measures in 2 different places, they were the R0, which I think everybody knows now, the reproduction rate was going down. In places where the old strain was, it was not going down, and where the B117 variant was. So that you would remember that, in January, UK actually went down into a very strict lockdown because they needed to control it. It was still growing. The R number was increasing, even with sort of medium shutdowns allowing some public movement. And it was only through that they were then able to, for 8 weeks, when they went to a very strict lockdown, that they were actually able to decrease the R numbers. And of course, now we can see that UK has rolled out the vaccination very aggressively. So there's no magic bullet. It's still the same thing. We have to do the public health measures. What we are saying is that we just have to do it better, right? So in some cases, they're saying wear 2 masks instead of 1 mask because we still don't know how easily the B117 can transmit. People have talked about whether you can catch it in elevators. So we're going back to almost to 360, not knowing exactly how quickly the virus can transmit. So stricter public measures, everybody trying a little bit harder and not relaxing about, it's okay if I don't do this one time, or it's okay if, we have a few people over. Every time we loosen those strict public guidelines, we increase the risk. And now we're reading that, there was one party in one place and 50 people got infected. There was one restaurant, in over 3 days, people are now being contaminated. So all of those, we know that the main transmission mode is through these super spreading events. So we really need to be very careful on how strictly we're following the guidelines of public health and bringing those numbers down. So that's really all we can do until we have a much more wider coverage by vaccines, which then balance the public health measures.
So speaking of vaccines, Dr. Richardson, you told us a bit before the panel about some interesting experiences you've been having delivering the vaccine in First Nations communities, where you've seen sort of a bit of an interesting reaction to news of the variants. Can you tell us a bit about that?
Sure. And, this is to preface, as people likely know, Indigenous adults in Canada have been a phase 1 priority just because of some of the inequities that I spoke about around the social determinants and the data bearing out with higher hospitalizations and mortality in the jurisdictions where we do have that data. And so in the federal government and provincial governments for some groups, depending on whether people were on reserve or off, had an aggressive vaccination strategy. And because of the experience of mistreatment of Indigenous people in the healthcare system, with forced experimentation, with forced tuberculosis vaccination, for example, in the Indian hospital system, and ongoing mistreatment, such as we see daily in many contexts, there was a lot of concern around vaccine hesitancy by Indigenous people to be vaccinated. Certainly, I've now vaccinated hundreds of Indigenous folks through various, both in urban settings and in remote First Nations. And I have seen that when we have clear and great discussions and dialogue, and it's an informed consent process, not forced, I've had 100% uptake. But I think one of the things I clearly noted around when we started to see the emergence of the vaccine, where, for example, I was asked to present at one urban Indigenous organization because of, quote, vaccine hesitancy, meaning people being worried, the people working there being worried about taking the vaccine because of those reasons that I've talked about. Suddenly that flipped when we had the emergence of the variants, and people were very worried, to people saying at that same organization, when can I get the vaccine? Like, I need to get this as quickly as possible. So even amongst people for whom there is this, who have been structurally marginalized and mistreated and may hence have higher rates of not being confident in the vaccine, I have seen certainly on the ground level how the concern and the fear that these variants are spreading figuratively actually has led to even more interest in getting the vaccine as quickly as possible.
Yeah, it's one sort of odd silver lining to the variant situation. I know the news about them worries and scares me too. One of the things I find myself up at night about is the idea that as the virus continues to spread unchecked in some places, that we'll see more and more variants emerge. Dr. Krajden, I know that's something that you and your colleagues at labs across the country are watching. So can you tell us a bit more about how you are tracking the emergence of new variants and how you separate out the ones we should be worried about from the changes that really don't mean anything at all?
I think we're all staying up at night thinking about the same thing. We're hoping that the combination of infections and vaccines will take this illness and transform it from a severe disease to and death-causing illness to more of a common cold. And the way we're doing that is in multiple jurisdictions, really monitoring for how effective the vaccine is and to try and understand how long that effectiveness lasts this is occurring here, this is occurring around the world. And then people are trying to understand, are there antibody or immune correlates that correlate with that protection? And again, it's not whether or not you have to protect someone from getting infected, it's can you protect them from getting severe disease or dying? And so the efforts are broad to try and monitor for existing or new variants using more and more of this whole genome sequencing, and then trying to link that data more effectively with the epidemiological data to determine what happened to someone who was vaccinated or not. And this is being done both in Canada as well as globally. And then I think the greatest challenge in our country, where we have 10 provinces and 3 territories, so we essentially have 13 countries, it's figuring out how we can better share the sequence data and the epidemiological data in real time. And as Lisa highlights, you still have to deal with the vulnerabilities of various populations and the racialized populations. And that's not solved by the virus itself. It's solved by us working as a society more effectively together.
Well, we're down to about 5 minutes left in this portion of the discussion before we get to audience questions. And I do actually on my screen have quite a bit of great questions coming in from the audience. So maybe I'll wrap up this portion just by turning back to you, Dr. Knoppers. Where do you see us in 6 months to a year? I mean, are the variants going to upend our dreams of having life go back to normal? Will we still be counting cases? Will we still be wearing masks? Will we still be waiting with bated breath to see if our children's schools will be closed the next day? What do you see ahead for us?
Well, I'll join the stay up at night crowd that's here in this panel. Even though I'm an idealist, I do think we're going to see 3 major changes that will affect our daily lives. The first is that public health is now political. We sort of all took it for granted. It was in the background somewhere. It is now going to be a strategic priority for governments, and hopefully not as a temporary, let's fix it kind of approach that we saw, let's say, with SARS about 10 years ago. So it has to be prioritized in terms of preparedness, prevention, and promotion. The second would be our daily lives will change in a cultural sense, in that our autonomous daily life will now be our daily public health life. And there's a loss of a degree of freedom there, but there's also a recognition that our own survival, but even beyond that, having a more sort of humane and coming back to a more human interaction society depends on being public health people. And finally, I think this is very sad. And in one sense, we're going to have to give up our ideal, that we are, global globetrotters and become global citizens. And I think that is going to be a major change. I think it's a good change. Maybe it took variants to get us there. But to realize that it's only as global citizens that we're really going to solve not only the variance issue, but also our own survival in a human sense.
Yeah. All right. Thanks a lot for that, Dr. Knoppers. All right. I'm going to turn to the audience questions now. And this first one, I have to say, is something that I personally find confusing a lot when I'm reporting on this. And this comes back to whether we need to change our behavior because the variants are more transmissible. So it is confusing when you say the variants are, X percentage more transmissible, but all the same old stuff works, just keep doing it, right? So this audience member asked, are there certain behaviors we've used against the original COVID-19 virus that will have to be modified? For example, do we need to be aware of what kind of mask we use? Should it be typical surgical mask, or should we all be upgrading to N95s? And do any of the variants stay alive longer on surfaces than the original virus? So would anybody like to jump in on that one? I see Dr. Richardson nodding, so maybe I can turn to you.
I was thinking that Charu should answer this one as a public health with their public health expertise.
All right, Charu, do you want to give this one a shot?
Yeah, I mean, I can get a go at it, but I'm sure Mel wants to add. So like I was saying before, that I think the same public health measures work. In Canada, we're not recommending double masking like some other places have, because I think using a mask well, but just using one that meets the guidelines, which is the 3 filter rule, is what it takes. Initially, there were some discussions around whether, the variants, which again, we shouldn't say variants as a broad category, because B117 is not the same as 351, is not the same as B1. The ones that are coming out of California have different properties, the one from New York. So that's why, it's very difficult to provide broad guidelines, but very specific to the variants. And of course, you're exposed to all of them. So that's why the public health advice hasn't changed. Everybody is saying that is be your most strict. So remember back in March, how strict you were about who you were seeing, how far you were keeping from each other, how you were worrying about every time you got out of the house. Until we have majority coverage by vaccines, that's the kind of thinking that we need to go back into again, instead of the last summer thinking where we were all outside and we were able to have a few, sort of meals outside in patios, or, go for walks in public places and make sure that we're not getting too close to everybody. So that kind of relaxation is what we need to avoid right now. We need to be back up on that 100% guard to make sure that, it's not spreading like wildfire, which, we are expecting that in every 2 weeks, we might see doubling or more.
Sorry, I have to follow up and ask, no outdoor walks, no outdoor meals?
But let's...
Can I let Dr. Krajden, he's got his hand in the air and wants to follow up on that.
I've often heard people talk about how many masks they should wear, and often you'll see people with an N95 mask and their nose is exposed. And part of it is we tend to focus in on these things which actually aren't as important as the fact that if you're outdoors, there's a lot of air circulation and you can be together. And if you look at the data, the risks increase when you're closely together. So part of that is that distancing issue. I think the hardest thing for people to imagine is the fact that there are some people who really can protect themselves. They're financially secure. They're able to live in a large home. They can protect themselves. There are others who have to go and work, and those people have trouble protecting themselves. And then there are those who don't even think this is important and go out and play, and they don't protect themselves, and then they take it home to their parents or other loved ones. So I think the challenge is you have a society that is quite tired of these measures, and these measures do work when they're adhered to and applied to. And with these variants, if they're more transmissible, it means you still have to work harder, and people are tired of doing that. We're hoping that with these vaccines rapidly deployed, not only in Canada, but globally, that we will take this infection from being one that causes severe disease and death to something that goes back to a common cold.
Well, one of the other questions we have from the audience addresses that very issue and just asks simply, is there a chance that the variants could cancel out our current vaccination efforts? If somebody could respond by kind of raising their hand nice and high, if anybody wants to deal with that question. All right, Dr. Kausic, over to you.
So, so far, there's no indication that any of the vaccines don't seem to work at all, right? So there's some hints that some of the vaccines, and the one thing that I want to remind us all is that, two of the vaccines, the Moderna and the Pfizer vaccines, were approved and deployed prior to variants emerging. 55% efficacy data is primarily related to before the variants, whereas the AstraZeneca, J&J, which are the other two that are approved in Canada, we have some real life data for that because they were deployed in multiple countries when the variants were emerging. And So they might on paper seem to have less efficacy, but we must remember that we don't have the equivalent data for Pfizer and Moderna. And also, we are now getting that data from countries like, for example, Israel and UK, and probably very soon from US as they, cover large portions of percentages of their population. So we get some real life data. But in terms of the work that the vaccine companies and other researchers have done, all vaccines look really good. In terms of what their coverage is, they all work against variants. There's no chance yet that the vaccines will really give no protection against, variants, and all our good work will be lost. So I don't think we need to worry about that yet. And the vaccine companies, and of course, many other people who know this area really well, are already planning ahead. So there are already changes to the vaccines that are being made that take into account that E484 mutation, which is the most worrying one that we've seen, that's there in a couple of the variants. And it's emerging much more frequently. So I think before long, we will have vaccines that are actually tailored towards the variants. And we might see that, next year, we may have a vaccine that mixes this vaccine along with that, kind of like flu, where there's 2 or 3 different kind of variants. And then we mix it all together and have a vaccine that addresses all of those. So no need to panic yet.
Okay, that's good to hear. Dr. Richardson, was there something you wanted to add there?
I just wanted to add that every time I start to feel a little, this is a tough time, and having the variants added to the whole, the stress that we're all experiencing now certainly can be overwhelming. So I often will look to the data out of Israel to give me just as a little boost. Mm-hmm. And the data out of Israel yesterday is that they're fully open. There are not, so the reproductive rate is going down. They've got 85% fewer deaths, 85% fewer daily cases, 79% fewer critically ill people. And this is in the context of a massive and effective vaccine rollout strategy where there were, and they know that there were variants present there. So whenever I'm starting to feel down, I do tend to look at that. And I was happy to see that data that was released yesterday, just as a little point of positivity.
Hey, I'm very happy to have any positivity you can offer. Oh, maybe Dr. Knoppers also has positivity to offer, because I see her hand.
I don't know. I mean, Israel, which is a country I visited, is a very cohesive, organized, hierarchical, like a unitary state. Let's put it that way. So to try and predict behaviors in other countries and drawing on Israel, I think Israel's stats are fantastic. And yes, they are positive. But can we emulate those behaviors? Do we have that level of social cohesion to the rules and to follow them the way we should as citizens? That's still, we're pretty freewheeling still in different parts of Canada as to, listening to our governments, put it that way, and our public health officials, right, Mel?
Yeah, the other thing I always find when I bring up the very encouraging stats from Israel is I will have people say, but wait, they gave everyone the Pfizer vaccine on schedule, 3 weeks apart. And so Canada, as you all know, is taking this position of advocating as much as 4 months between the first and second dose of the vaccine. And that is another audience question that we have now. And this member of the audience wanted to ask, could my immunity decrease to the point between these 2 shots that I could get sick from a variant in the meantime? Can I ask Dr. Kausic about this? Because I know she's our immunity expert.
Okay, so Mel is laughing because he and I have had many, many discussions on this. We sit on many of the same committees. Mm-hmm. From a public health point of view, I completely agree with Mel, that if we can bring the numbers down very quickly with very aggressive rollout, the first dose of vaccine, the virus can only mutate if it can replicate. right? So if we shut down its replication by controlling its transmission and how much it can replicate, definitely we can control, the variants and the evolution of variants. The other part of it is that I do agree that some of the vaccines are new platform vaccine. As an immunologist, I still worry about what that means. So I know the vaccinologists will swear by it and everybody swears by it, but the data is the data, and we don't have data whether 4 months is enough of a spread and we will have same degree of efficacy. Will you completely lose efficacy? Absolutely not. The immune system is not a button. You can't turn it on and off. So you lose it over time. But there is data that's now coming out showing that, for 65 and over, after the first dose, in 2 or 3 months, the immune system starts going down. The immunocompromised people, the immune system is not as good, and you don't get as good a response with the first dose. Same thing with, the older adults. So I'm not sure that the one size fits all work for the interval that is the current guidance. I think there might be some nuances that might have to be brought in for those whose immune system is either weak or is not good. And that's, I think, probably where the public health advice will go. But I'm sure Mel can add more to that.
Yeah, I want to give you an opportunity to add to this. I think just to let our audience know is that the BCCDC has been, one of the leaders in advocating for this delayed dose strategy. So tell us why the BCCDC has taken that position.
Well, I think Charu outlined all of the critical points that if you look based on what the publications are, you'd want to adhere to this, to the dosing schedule. But the reality is you're faced with a shortage in supply, a slow delivery, and you're basically left with the choice that you might give someone a suboptimum dose in terms of the amount of the immune response, but it might be enough to protect them from death or severe disease. And both Quebec and British Columbia have been tracking with that deployment of that single dose what is happening to our vulnerable elderly population and our healthcare workers. And what we're seeing is a very precipitous decline in severe disease and death, akin to what has been described in Israel. And whether it's 3 months or 4 months, at the end of the day, by protecting more people faster, the net benefit to us as a society is that you'll have fewer deaths or severe disease. And then we'll learn whether this is the right thing. And it seems controversial, but for many other vaccines, delaying the second dose actually produces a more robust immune response.
All right, we are down to about 2.5 minutes left in our time together. So I wanted to get to one last audience question that I think is on a lot of people's minds right now. And this one has to do with preferences for certain brands of vaccine. The AstraZeneca vaccine in particular has been in the news a lot lately in a way that I think is really confusing and difficult to follow. So this member of the audience asked, preferences have emerged in my community for certain vaccines. People seem to want Pfizer, but not AstraZeneca. Is there a ranking for vaccines? Should I wait until I can choose a certain brand, particularly since some seem to work better than others? Though I'm happy to offer this up to anyone who wants to take it. Mel or Dr. Krajden, pardon me, is raising his eyebrows, and Dr. Knoppers is raising her hand as well. Maybe I can give you the last word here.
Well, I'll give you a very non-scientific answer. In a universal healthcare system where you want to maximize the public good across whole populations, you take what you can get subject to the scientific advice that is the best in Canada. And I think we are very, as Canadians, we value a universal healthcare system, its portability, accessibility, equitability, and so on. So I think that would be the attitude that we should have. And these vaccines have been vetted.
Okay, that's good to hear. Dr. Kausic, want to add anything there?
No, I think Bartha's put that very clearly, but just to reassure the public, I will go and roll up my sleeve for the first vaccine that's available because they protect you from severe disease and death. They're equally good, and that's really what you want to protect yourself against. So I think that's really the public advice because, Mel and I can argue till the cows come home versus the public health, whatever. But the bottom line that we all agree on is that these are good vaccines. They will protect you, and you should take the first one that you can get.
Yep. Maybe we could all raise our hands if we'd be willing to take the first Health Canada approved vaccine we were offered. All right. I think that's a nice note to leave it on. We have run out of time for today's event. On behalf of the Globe and Mail and the Royal Society of Canada, I want to thank all of our panelists for joining us today. And thank you as well to our supporters at the SSHRC, NSERC, and the CIHR. Just a reminder to the audience that you will receive a link with a recording of this webcast if you'd like to watch it again. And if you enjoyed this and are you interested in joining one of our future town halls, our next one has just been scheduled. It's going to be held at 2 p.m. Eastern on Thursday, April 29th, and it will be a subject I know everyone is interested in, and that is the vaccine rollout. Where are we at now? Thanks very much for joining us, and have a great afternoon.